I'm Margot Hudson. I'm a physician at Brigham and Women's Hospital, and in the next session we will discuss endocrine crises encountered in the ICU. I have no financial disclosures. These are the topics that I will cover: thyroid storm, amiodarone-induced thyrotoxicosis, myxedema coma, adrenal insufficiency, and hypercalcemia. First, I'd like to review thyroid function tests in the ICU. I'd like to discuss primary hyperthyroidism. In this case, when TSH is ordered, it will be markedly low or undetectable in association with an elevated free T4 level and often, but not necessarily, an elevated total T3. In primary hypothyroidism, TSH will be elevated, free T4 will be low, and the total T3 could be normal or possibly low. In secondary hypothyroidism, which is hypothyroidism due to pituitary or hypothalamic problems, TSH will be normal or low. The free T4 will be low. And again, total T3 may be in the normal range or low. Then finally, there is the difficult to diagnose problem of non-thyroidal illness, thyroid function test abnormalities. In this situation, TSH can be normal or low. Free T4 can be normal or low. But if total T3 is looked for, it is often significantly decreased. This shows you an overlap of the different thyroid function tests looking at free T4 and TSH. And what is clear is that non-thyroidal illness will overlap with normal thyroid function tests, central hypothyroidism, even mild hyperthyroidism. So it always is a concern when interpreting thyroid function tests in patients in the intensive care unit. What about some drugs that can cause changes in thyroid hormone? Drugs that will suppress TSH include dopamine and the use of high-dose steroids, which acutely can suppress TSH. Drugs that can cause primary hypothyroidism include lithium. This effect is generally long-term. Drugs that can cause both hypo and hyperthyroidism include amiodarone, frequently encountered in the intensive care unit patient. And newly noted is biotin, which can falsely elevate thyroid function tests and result in misdiagnosis. Now let's turn to accelerated hyperthyroidism or thyroid storm. First, I'd like to discuss the criteria for this. The clinical features include fever, gastrointestinal symptoms or jaundice, tachycardia and or atrial fibrillation, heart failure, and neurologic changes such as restlessness, delirium, psychosis, and ultimately patients can develop stupor, seizures, and coma. One of the problems is that from a laboratory standpoint, there are no laboratory features which will distinguish thyroid storm from usual hyperthyroidism. Some findings that can suggest it include LFT abnormalities, hyperglycemia, hypercalcemia, and azotemia. In order to try and distinguish if a patient with hyperthyroidism is at risk for thyroid storm, a point scale called the Birch-Wartofsky point scale has been developed. I am not actually going to show that because it has it's quite extensive, but I do suggest that you look at it. And a score over 45 is consistent with thyroid storm. over 90% of patients who are diagnosed with thyroid storm has as their underlying thyroid abnormality Graves' disease. Mortality can remain a significant problem in thyroid storm, with 8%, as high as 8% in a recent series. Major precipitants to thyroid storm include infection, surgery, treatment with I-131 for the hyperthyroidism itself, IV contrast exposure, abrupt cessation of antithyroid medication by the patient, and patients with toxemia in pregnancy. What about managing patients once thyroid storm is diagnosed? Again, because of the considerable mortality, patients should be monitored in an ICU setting. Initial treatment should be with antithyroid medications. These medications will inhibit the production of thyroid hormone by inhibiting organification of iodide. The two that are available for this indication in the United States include PTU and methimazole. In general, PTU in thyroid storm is preferred over methimazole because of it can also inhibit peripheral conversion of the T4 to T3. This is one of the few instances where PTU is preferred over methimazole. An initial dosing of 500 to 1,000 milligrams, followed by 200 milligrams every 4 hours, is effective. A major concern about use of PTU is liver dysfunction, which generally happens in after chronic use rather than acute use. After antithyroid medication is started, there should be administration of iodine. Iodine can help block the release of preformed thyroid hormone. If possible, it should be started after the initial dose of PTU. And a common way of administering iodine is to give SSKI 5 drops every 6 hours. Along with the iodine, corticosteroids should be administered. If thyroiditis is present, this will help suppress that. It will also, glucocorticoids will also decrease the T4 to T3 conversion and help support a stress response. Common doses include 8 milligrams of dexamethasone a day or hydrocortisone, 300 milligrams IV initially, and then 100 milligrams IV Q8 hours. Administering a beta blocker will help slow the tachycardia associated with thyroid storm. Beta blockers can also decrease T4 to T3 conversion. Most commonly used is propranolol, 60 to 80 milligrams every 4 hours, or esmolol as an IV infusion. In cases where beta blockers are contraindicated, diltiazem could be considered. It is also important to initiate supportive measurements for patients in thyroid storm. Acetaminophen is preferred for the fever over salicylates because aspirin will displace T4 from thyroid binding globulin and increase free hormone levels. In the patient with fever, external cooling should be avoided because shivering may actually increase core body temperature. These patients are frequently dehydrated, and fluid administration should be given. However, in the patients with heart failure, cautious use of diuretics should be considered if necessary. Again, management of heart failure in a hyperthyroid patient can be quite difficult. If the patient still remains in thyroid storm after all these measures, there are case reports describing use of plasmapheresis or dialysis to lower the thyroid hormone levels. And cholestyramine can help bind thyroid hormone, which does go through enterohepatic cycle. Frequently, patients will be seen in the ICU setting with amiodarone-induced thyrotoxicosis. This is one of the most difficult conditions to manage. Patients with this are very ill both from their cardiac disease as well as their thyroid problem. 10% mortality has been reported in amiodarone-induced thyrotoxicosis. In the United States, most AIT is due to thyroiditis, meaning destruction of the thyroid gland from the amiodarone, rather than hyperthyroidism, which is excess synthesis of thyroid hormone. Doppler study of the thyroid can help distinguish hyperthyroidism with a high flow from thyroiditis, which would have low flow to the thyroid. However, these are very difficult to interpret and therefore may not be that helpful. Steroids are the most effective treatment for AIT due to thyroiditis. But if hyperthyroidism is suspected, methimazole up to 40 milligrams a day can be used. Iodine itself is ineffective because of the high iodine content of the amiodarone. Perchlorate in many guidelines is suggested for management, but unfortunately it is not available in the US and therefore is not used. And ultimately, many of these patients who cannot be controlled may require surgery to treat their hyperthyroidism. Now let's turn to myxedema coma. The definition of myxedema coma actually is neurologic depression due to severe thyroid hormone deficiency, and actual coma is not necessary to have this. Mortality is very high in patients with neurologic depression due to hypothyroidism, being upwards of 30 to 50%. The primary precipitating factors for myxedema coma include medication noncompliance, exposure to cold weather, concurrent infection, myocardial infarction, or stroke. CNS depressant medications such as narcotics, anesthetics, and sedatives given often in the hospital can also precipitate myxedema coma in a hypothyroid patient. What are the primary features of this condition? Lethargy, obtundation, coma, and seizures can be seen. In association, bradycardia, hypotension, and hypothermia can be detected. Hypoventilation with CO2 retention is quite common, and patients often will have hyponatremia because thyroid hormone generally will suppress ADH, and in the setting of thyroid hormone deficiency, ADH is excessively secreted. Patients also can have gastrointestinal involvement with ileus, making oral absorption of thyroid hormone problematic. What are the criteria for diagnosing this? In the appropriate clinical setting, thyroid function tests that are consistent with severe hypothyroidism in a patient with neurologic changes should be sufficient to warrant this diagnosis. 95% of these cases are due to primary hypothyroidism, and TSH will be noted to be quite elevated. However, 5% of cases of myxedema coma may be due to central or secondary hypothyroidism, and in this setting, TSH will not be elevated. Treatment should involve supportive care, in particular, active rewarming. It can cause cardiovascular collapse and hypotension. Hypotonic fluids should be avoided because of the tendency to have excessive ADH levels, and patients can become quite hyponatremic. Because of the CO2 retention, ventilatory support may be required, and because frequently infection is a major precipitant of this condition, empiric antibiotics should be considered. When a patient is felt to have myxedema coma, they should be treated initially with glucocorticoids. Doses in the range of 50 to 100 milligrams 3 times a day for several days should be sufficient. Patients with myxedema coma may have primary or secondary adrenal insufficiency, and therefore, before giving glucocorticoids, they should be screened, if at all possible, for adrenal insufficiency. After glucocorticoids are given, thyroid hormone can be administered. For most patients, 300 to 500 micrograms of T4 given IV, followed by 100 micrograms IV every day, should be sufficient to resolve the neurologic changes. Some institutions will use a combination of T4 at 50% of this dose with T3, 10 micrograms IV given every 8 hours. When the patient becomes alert and is able to take PO, they can be switched to oral replacement if they do not have an ileus or some other impediment to absorption from the gastrointestinal tract. The improvement in mentation, temperature, pulse, and sodium should occur quite quickly with adequate initial therapy, but the TSH may take longer to respond and therefore is not a good measure of progress. What about treating the patient in whom you suspect coronary artery disease? So coronary artery disease is common in patients with hypothyroidism. And patients with untreated hypothyroidism may not notice symptoms of their coronary artery disease. Therefore, if coronary artery disease is suspected, T4 replacement may be given at lower doses in the range of 200 to 250 micrograms IV as a one-time dose. And this should be safe and help reverse the neurologic impairment, followed by 25 to 50 micrograms of IV T4 daily. Now let's turn to adrenal crisis. Here is an old-fashioned pathology slide of the adrenal gland showing all the different layers. We have the zona glomerulosa, which produces aldosterone, the zona fasciculata, which produces corticosteroids, cortisol. Zona reticularis produces the adrenal androgens, and in the medulla, catecholamines are produced. I want to review the hypothalamic pituitary adrenal axis. First, ACTH stimulates the secretion of cortisol as well as aldosterone. But the renin-angiotensin system and potassium are the primary regulators of the production of aldosterone. So, in the absence of ACTH, cortisol is not produced. But if ACTH is absent, aldosterone can be secreted from the renin-angiotensin system and potassium stimulus. Primary adrenal insufficiency is adrenal failure, and secondary adrenal insufficiency is pituitary or hypothalamic failure, and secondary adrenal insufficiency is associated with loss of ability to produce ACTH. This is just a schematic to show the hypothalamic pituitary adrenal axis. The hypothalamus produces corticotropin-releasing hormone, which then stimulates the anterior pituitary to produce ACTH, stimulating the adrenal gland to produce cortisol. The cortisol will then feed back on both the pituitary and the hypothalamus. While ACTH will stimulate production of aldosterone, angiotensin and potassium are the prime stimulators of aldosterone production. So what happens in acute adrenal crisis? The primary effects of cortisol are to maintain blood pressure by sensitizing vascular smooth muscle to catecholamine pressor effects, to antagonize the effect of ADH on water excretion and to suppress ADH secretion, and to increase hepatic gluconeogenesis. What are the effects of aldosterone? Sodium retention, potassium excretion, help maintain extracellular volume, and increase vascular resistance. So in acute adrenal crisis, you have loss of glucocorticoid with or without loss of mineralocorticoid. Some of the symptoms include nausea and abdominal pain, fatigue and weight loss, hypotension, fever, hyponatremia, eosinophilia, and hypoglycemia. So all of those could be seen. When trying to decide if a patient might have primary versus secondary adrenal insufficiency, some clues would be in primary adrenal insufficiency, hyperkalemia may be present. If it has been long-standing, the patient may have hyperpigmentation due to to elevated levels of ACTH, and the patient will also have dehydration and hypotension. In secondary adrenal crisis with pituitary or hypothalamic failure, there tends to be less hypotension because the aldosterone can continue to be produced. There often is greater symptoms of hypoglycemia due to loss of some other pituitary hormones, such as growth hormone, which also help maintain glycemic levels. Well, what are some of the precipitants of acute adrenal crisis? So anything that can cause an acute physiologic stress in a patient who has an underlying mild adrenal insufficiency can precipitate an acute adrenal crisis. Frequently, abrupt cessation of glucocorticoids in an adrenally sufficient patient will precipitate this. This is seen either with rapid tapering of glucocorticoids in a patient who has been on high-dose steroids for a long time, or in the patient who discontinues their long-term steroid therapy. Failure to increase stable doses of glucocorticoids in the setting of acute physiologic stress can also precipitate acute adrenal crisis. Bilateral adrenal hemorrhage is a precipitant of acute adrenal crisis, pituitary infarction, and medications that inhibit cortisol production, such as etomidate, ketoconazole, and migestrol. With migestrol, this is a more difficult situation because it acts as a glucocorticoid. So in the patient on long-term migestrol therapy who stops it acutely, they can also develop acute adrenal insufficiency. So how can adrenal insufficiency be diagnosed? The ACTH stimulation test is the standard for measuring adrenal function. The standard test is 250 micrograms of ACTH given IV or IM. There is a literature on using the low-dose test, which may be helpful in diagnosing patients with recent onset pituitary or hypothalamic failure causing adrenal insufficiency. When interpreting cortisol levels, random morning cortisol can be quite helpful. If a morning cortisol level is below 3 micrograms per DL, that makes adrenal insufficiency a likely diagnosis. If the random morning cortisol is greater than 11, it makes adrenal insufficiency unlikely. If after giving the ACTH and measuring cortisol at 30 or 60 minutes, the value remains below 18, adrenal insufficiency is likely. If the level goes up above 20, adrenal insufficiency is unlikely. So just a word about measuring steroids, that cortisol levels can be falsely elevated by cross-reactivity to administered drugs. So this happens all the time and causes a great deal of confusion. So hydrocortisone given IV or PO, of course, will be picked up by by all cortisol assays and can lead to levels that appear falsely high. Prednisolone and prednisone will have some cross-reactivity, and therefore interpreting values with patients on either of these can be quite problematic. The commonly used glucocorticoid which does not cross-react in assays is dexamethasone. When dexamethasone is given, cortisol levels can be interpreted. However, dexamethasone, of course, will suppress baseline cortisol levels, but it will not interfere with the response to ACTH. So other helpful tests in distinguishing primary from secondary adrenal insufficiency. In primary adrenal insufficiency, basal ACTH level will be elevated, which is not seen in secondary. And aldosterone will respond to ACTH stim in secondary adrenal insufficiency when the adrenal gland itself is normal, but aldosterone will not respond to ACTH in primary adrenal insufficiency. So either getting an ACTH level prior to doing the ACTH stim or adding aldosterone levels to the ACTH stim should help you distinguish primary from secondary adrenal insufficiency. Now, what about turning to treatment? Initial treatment should be normal saline or D5 normal saline, 1 to 3 liters over 12 to 24 hours. 50 milligrams of IV hydrocortisone every 6 hours for 25 hours, then taper to 50 milligrams IV every 8 hours should be sufficient for management of even the most stressed patient. Remember, if you give dexamethasone, it will not supply any mineralocorticoid replacement in patients with primary adrenal insufficiency. However, if they are on saline, this should be adequate to replace, to maintain their blood pressure acutely until diagnosis can be established. Average maintenance doses for patients who are diagnosed with acute adrenal insufficiency include hydrocortisone, 15 to 20 milligrams every morning and 5 to 10 every evening. And in those patients with primary adrenal insufficiency, fludrocortisone, 0.1 milligram a day for mineralocorticoid replacement should be adequate. What about the topic of critical illness-related corticosteroid insufficiency? So this is quite controversial, and I'm not sure I'm going to actually end the controversy, but I can bring you up to date as to what is known at this point. So in critical illness, cortisol-binding globulin may be decreased. So this will lower the total measured cortisol, but it doesn't actually lower the free cortisol. However, most hospitals do not have assays clinically available for measuring free cortisol levels. The other physiologic change that is seen in cortisol metabolism is that degradation of cortisol is decreased, so this prolongs the half-life. And our standard thinking that 200 milligrams a day of cortisol is the stress dose to be replaced may actually be far more than necessary. So you have two competing effects. One, the lower CBG levels leading to a lower measured cortisol, and two, the prolongation of the cortisol leading to lower total daily cortisol needs. And I just want to show you a recent study looking at this, trying to explain this. This shows cortisol production in patients, in control patients versus patients in the ICU. And this shows that the average cortisol production rate over 24-hour in a stressed patient is actually far lower than we thought, in the range of 60 milligrams per day. This shows that the plasma clearance rate in stressed patients is actually much lower than controls. So, what should be done in the intensive care unit? That the possibility of relative adrenal insufficiency as a concept has been raised in septic patients who have had refractory hypotension. And the concern was that these patients might benefit from treatment with glucocorticoids. However, treatment with 200 milligrams per day of hydrocortisone has only inconsistently been found to improve mortality. So some studies have shown a positive benefit and other studies have not shown benefit. Generally, doing ACTH stim testing in patients with normal baseline cortisol in the ICU is not recommended at this point because it is difficult to interpret. And treatment with glucocorticoids should really be reserved for selected patients who there is significant evidence of cortisol deficiency, in whom there is significant evidence of cortisol deficiency. So I just want to go over a case that we saw at our institution that I think is illustrative of some of these concepts and the types of complicated patients that may present to your institutions. This was a 22-year-old female with known hypothyroidism and celiac disease who went to her local emergency room with the worst headache of her life. She said that she had missed a few doses of her thyroid hormone but had recently restarted it. She denied any other symptoms other than the headache. She had a CT scan which showed no abnormalities, and an LP was done which showed very high manometer readings. She had labs drawn which were consistent with primary hypothyroidism, showing her TSH quite elevated at 151, her total T4 that was low at 2.4, total T3 in the normal, in the low range, normal being 80 to 200. Her glucose was 52 milligrams per DL, sodium 131, potassium 4.3. After her lumbar puncture, she had acute deterioration in her mental status, and she was treated urgently with mannitol and dexamethasone and transferred to the ICU. In the ICU, she received 63 micrograms of IVT4, and 30 hours after her transfer, she became her mental status improved, but 30 hours after the transfer, she became acutely hypotensive and required pressors. So the question was, what happened? Why did she become hypotensive? So she did have laboratory studies done at the time of the hypotension, which showed a cortisol of 0.6 micrograms, an aldosterone that was undetectable, an ACTH that was 1100 with normal up to 30. And she actually had antibodies to the 21-hydroxylase enzyme CENT, which came back 2 weeks later, of course, that was consistent with Addison's disease. So how can we put this together? This is a patient who had known hypothyroidism. She was inadequately treated because of noncompliance, and she also had undiagnosed adrenal insufficiency on the basis of her polyglandular failure. She developed pseudotumor cerebri and was given dexamethasone, which actually covered her stress-related adrenal insufficiency for a short period of time. But after replacement of thyroid hormone, she actually developed an acute adrenal crisis. This speaks to how complicated these patients can be and the benefit of treating patients with glucocorticoids in the setting of neurologic change and hypothyroidism. Now let's turn to the last topic, hypercalcemic crisis. So there is no accepted definition, but one is a useful rule of thumb is a corrected serum calcium of over 14 milligrams per DL. And in the patients with low albumin, you can add 0.8 milligrams per DL of calcium for every 1 milligram below 4 for the albumin. The symptoms of patients with hypercalcemic crisis include polyuria and dehydration due to concentrating defect with a nephrogenic diabetes insipidus picture. Patients can also have nausea, vomiting, abdominal pain, and confusion, somnolence, and coma with hypercalcemia. Laboratory and radiologic abnormalities may show renal dysfunction, pancreatitis, ectopic calcifications including nephrocalcinosis, and EKG changes including shortened QTc interval, heart block, and ventricular arrhythmias. Malignancy is the primary cause of a hypercalcemic crisis, occurring in 50% or more of patients. However, parathyroid hormone can mediate about 25% of hypercalcemic crises. Usually it is primary hyperparathyroidism, but parathyroid cancer, while rare, does occur and can cause this. Vitamin D excess, granulomatous disease can cause hypercalcemic crisis, as well as rarer causes such as hyperthyroidism, vitamin A excess, and immobilization. Treatment for hypercalcemic crisis should include vigorous IV saline hydration with a goal to maintain urine output over 100 to 150 cc's per hour. Furosemide should only be used in acute fluid overload. Calcitonin at a dose of 4 units per kilogram sub-Q every 12 hours can offer quick improvement in calcium levels. IV bisphosphonate therapy should be used early on, but remember that the response to this is delayed up to 48 hours, and IV bisphosphonates should be avoided in patients with significantly reduced renal function. If used, pamidronate 60 to 90 milligrams IV given over 2 hours can be used, or zoledronic acid 4 milligrams IV over 15 minutes. If zoledronic acid is available in your institution, this is currently preferred. What about alternatives if the hypercalcemia persists? Cinacalcet, 30 milligrams orally 1 to 2 times per day for primary hyperthyroidism, can be used as a bridge to surgery. Glucocorticoids, such as a dose of prednisone, 40 milligrams a day, can be used and are effective in vitamin D toxicity, granulomatous disease, or myeloma. Denosumab, 120 milligrams sub-Q, can be used if malignancy is suspected. And dialysis may be required in patients with severe renal failure. So just to summarize, thyroid storm, the diagnosis requires a clinical suspicion in the appropriate setting, and prompt treatment should include antithyroid medication, iodine, dexamethasone, and beta blockers. For myxedema coma, the diagnosis requires clinical suspicion in the appropriate setting, and treatment will include IV steroid replacement as well as IV thyroid hormone. For adrenal insufficiency, diagnosis can be confirmed by ACTH stimulation testing. Treatment includes glucocorticoid replacement and mineral corticoid replacement if primary adrenal insufficiency is present. For hypercalcemia, fluid replacement with saline is the initial therapy. IV bisphosphonate therapy can be given if there is adequate renal function, and the underlying cause needs to be identified so that specific treatment for that cause can be initiated. Let's turn to a question. Now, a clinical question. 84-year-old woman presents to the emergency room with obtundation, hypotension, low core body temperature of 96. Her thyroid function test showed TSH of 168 with normal up to 5, free T4 of 0.3, normal 0.8 to 1.8. So her diagnosis is primary hypothyroidism, central hypothyroidism, non-thyroidal illness, or congenital absence of thyroid-binding globulin. And I think that hopefully it's clear to you that the diagnosis is primary hypothyroidism, and we know this because of the marked elevation in TSH in combination with low T4 in this clinical setting. She does not have central hypothyroidism because of the TSH elevation. This, again, is not non-thyroidal illness because of the TSH elevation and the clinical setting. And the congenital absence of thyroid-binding globulin would perhaps result in low total T4, but the free T4 when measured would be normal. Let's go to question 2. A 28-year-old female, 2 months postpartum, presents to emergency room with progressive fatigue and orthostatic hypotension. Her labs include a sodium of 131, potassium 4.8, and an elevated ACTH. She has an ACTH stim showing a baseline cortisol of 2.3, going to 3.5 at 60 minutes. Her most likely diagnosis is Sheehan syndrome with secondary adrenal insufficiency, primary adrenal insufficiency, corticosteroid insufficiency and critical illness, surreptitious use of dexamethasone, or Cushing syndrome with steroid excess. So again, her diagnosis is primary adrenal insufficiency. This is not Sheehan syndrome because the ACTH is elevated. This does not fit the picture of corticosteroid insufficiency. Surreptitious use of dexamethasone would result in a suppressed ACTH. And Cushing's disease from a pituitary adenoma may result in elevated ACTH, but the cortisol level would be high and not low. And question 3. An 82-year-old woman presents to the emergency room with obtundation and is found to have a calcium of 16 and a creatinine of 4. Her initial therapy should include saline, IV zoledronic acid, oral phosphate, or dialysis. An initial therapy should include saline infusion. Saline infusion should be tried in all patients to see if renal dysfunction can be reversed. IV zoledronic acid may be helpful, but this is not. This should be deferred until renal function can be reassessed. Oral phosphate replacement should not be used for hypercalcemia, as this will result with increase in ectopic calcification. And dialysis, while potentially required, would not be the initial therapy until all other methods had been tried. Again, I have no financial disclosures.